here. Thank you all for coming to Grand Rounds this quarter. So we are going to be hearing from two residents with the Sioux Falls program who spent a month in Zambia doing a prenatal care quality improvement project. So Dr. Selvey and Dr. Quade are going to be talking today, and Dr. Heyer is here also, but mostly just as a resource. So Dr. Selvey went to Concordia College in Moorhead for her undergrad and graduated from the University of Minnesota for her medical school education. She's been here at the Center for Family Medicine in Sioux Falls, and we'll do graduating this spring, and then we'll do an OB fellowship next year. And after that, we'll go back to practice near her hometown, Wadena, Minnesota. And then Dr. Quade went to SDSU for her undergrad, and then Edward Via College of Osteopathic Medicine. So she is also graduating this spring from CFM, and then we'll also do a year of OB fellowship, and then we'll be going to Millbank to practice. So here they are.
Thank you. All right. Yeah, so we'll be talking a little bit about some of the work that we did in rural Zambia this last July through August of 2021. And then these are just kind of the front row pictures of what the clinic looks at, like at Chifundo. And then the three of us, Dr. Quade, myself, and Dr. Heyer, who went on the trip.
Yep, and then this is just the name of the clinic, Chifundo. And then like this is the main road in Zambia that you can see behind it. This is just a picture of where we stayed in the campus where the clinic is located in Africa, kind of from like an aerial view. So that's kind of like what some of the buildings and stuff looks like.
And so kind of before we talk about our project that we worked on in Zambia, we'll talk a little bit about prenatal care and then prenatal care specifically in the United States. So really when we're talking about prenatal care, we're talking about care that refers to pregnancy-related care. That includes screening and treatment for medical conditions, risk identification to try and help prevent poor birth outcomes, poor maternal outcomes, and then treatment and interventions such as, appropriate glucose control or more preventative measures like baby aspirin. And then studies have shown that prenatal care can be more effective if you identify pregnancy early, do education earlier on and throughout pregnancy, and then utilize risk factor modifications. And regular visits throughout pregnancy as well as postpartum are a big part of that as well. So in the United States, this is based off of a 2019 study. About 77.6% of live births were to women who had received early prenatal care, and that's defined as in the first trimester. 16% of women were receiving prenatal care starting in the second trimester, and then about 6.4% of women received late or no prenatal care. And many of these studies have shown that late or lack of prenatal care has major impacts on both mom and baby morbidity and mortality. And these are just some of the examples that puts them at risk. Some of these patients will come in with preeclampsia, unknown abnormalities such as placental location, and inability to effectively plan because they did not get any prenatal care or late prenatal care. So we have a harder time preparing for complications of pregnancy and postpartum complications. So benefits of prenatal care, these are just some of the ones that were found in a recent ACOG study, but increased risks of experiencing neonatal death if there has been no prenatal care or late prenatal care, especially if it's at 36 weeks or later. And then lack of prenatal care is associated with a 40% increased risk of neonatal death. In Black women specifically, they are greater than 3 times as likely as white women to not have received prenatal care. And then for Black and white women combined, not having prenatal care just significantly increases their risk of neonatal death by premature rupture of membranes, placenta previa, and fetal growth restriction. So thus it's argued that prenatal care is so important because it could be theoretically preventable.
So we'll kind of transition into like Zambia and where we were at and located. So on the right side, this is a picture of Africa, and then highlighted in red is where Zambia is specifically located. And then if you look on the left side, down here is what Zambia looks like. And then in this red highlighted area, that's the specific districts that we were located in. So this orange one right here, the Rafunza district, is where Chifundo is located. And just to kind of like point out, Chongwei is where one like the lower level referring center. And then Lusaka is their biggest city, which is like their major referral center. And so where we are located to Lusaka is about a 2-hour drive. So some background to why we wanted to do this. So antenatal care is any prenatal care prior to 14 weeks of gestation. It's been a longstanding problem at the Chifundo Rural Health Care Center and kind of in Zambia as a whole. At the beginning of this project, the pregnant women seeking antenatal care before 14 weeks was at 28%, and like at our center, and then 36% in the Rafunza district as a whole. So we had a lot of improvement that we could work with there. To show you kind of what our specific catchment area is in Chifundo, our clinic was located here. So this is that major road that you had seen from the clinic. From here to here is about 10 kilometers. And then these are some of like more of our outreach locations that end up coming to our clinic. And as you can see, our outreach even goes like across the river. So in the rainy season, it's tough for these patients to get to our clinic because they have to cross the river, which is going to be pretty high. They might not even be able to get there.
And many of the patients that are coming from these outreach sites come on foot. A lot of times we actually took vehicles to these sites, and they take, an hour to 2 hours by vehicle. So you can imagine how long it would take by foot for some of these patients that are coming to our Chifundo clinic.
Because we walked to here, right, Dr. Heyer? Yeah, so we walked here, and that's 2 kilometers. And then back that day. So that kind of gives you a little bit. Our patients walk very, very far to get to where we're located.
So our prenatal project was identified due to, the Ministry of Health in this area wanting to increase access to prenatal care and prenatal care outcomes. And so, due to poor performance or, areas of improvement for prenatal care, we came up with this project to try and help with maternal and neonatal outcomes. So our goals of our for our quality improvement project were to specifically look at increasing antenatal visits occurring before 14 weeks of pregnancy. And then as a result, hopefully increasing prenatal care that will come with that. And then looking at early identification of pregnancy, and then identification of related complications through risk assessment, and then ability to be able to intervene with any risks that come up.
So the aim of our quality improvement project was to increase the number of pregnant women receiving antenatal care before 14 weeks from their current 28% to 60% by December of 2021. So that was our aim for the study. How we did this was we did daily health education about the importance of early antenatal care to any woman that was of childbearing age, ages 12 to 49. We documented the LMP at every single visit, and then we performed a pregnancy on any woman of childbearing age, so age 12 to 49. And then if they did have a positive pregnancy test, we made an appointment that day to be seen. So they got like that education, and then they were like scheduled like to come back at like 4 weeks. It helped us also identify like estimated dates of delivery, because in Zambia, a lot of those EDDs were off because they don't have a lot of prenatal care prior to 14 weeks. And then we started to implement a screening tool that we'll talk about a little bit later to just assess the risk for preeclampsia at that first prenatal visit, and just kind of talk about risk factors in general that they could potentially screen for if they were to catch these patients before 14 weeks.
And so some of the basic OB care that is performed in the first trimester in the United States is as follows. We have generally quite a bit of screening that takes place, and that includes type-in screens, HIV screening, hepatitis screening, rubella status, and so forth. Also based on individual risk factors, we look at potential for early gestational diabetes screening or overt diabetes screening, thyroid, preeclampsia labs if they have a prior history or a high risk for having preeclampsia, and so forth. And, generally, most people are getting early first trimester ultrasounds to confirm dating as well. And then genetic screening, depending on patient's preference.
So in the Chifundo clinic, this is what we had for resources. So we do have a glucometer, so we can spot check glucoses. They do have a hemoglobin, or you can check for a hemoglobin, which is nice. They do malaria test their patients, and they actually prophylactically treat for malaria in pregnancy. We have a urine HCG to test for pregnancy, a urine dipstick, which they do at every single visit to look for signs of infection. There's quite a bit of sexually transmitted infections in Zambia. So if they do have a positive urine, they actually treat at every single visit. And then they have H. pylori testing, rapid HIV testing, and confirmatory testing. And then if they do have HIV, they have CD4 counts and viral loads. The district, or Zambia as a country, it does a really, really, really good job with HIV testing, and they have like a specific program to try to get this under control, which was very, very helpful. They also did have COVID testing and still do have COVID testing when we were there, and they were testing all of their patients. And then occasionally they'll have RPRs, which just depends on what their resources are at the time. And then kind of for our clinic in general, they also had an EKG machine, which was very abnormal for a small clinic. We actually toured one of the hospitals in Lusaka, and somebody spilled some type of liquid on their EKG machine. So legitimately the hospital, like a referring hospital, did not have an EKG machine. They also had an ultrasound that we were able to use. And we'll talk about that a little bit later too. And then they had a Doppler and continuous fetal monitoring options available for them, which is also quite unheard of in Zambia as a whole.
And Chifundo is seen as one of the rural clinic outreach sites. We do refer to Chongwe and Lusaka for higher risk things, but they have a lot of resources that are abnormal to clinics their size.
Mm-hmm.
So Chifundo, with the help of Dr. Heyer, have a lot of good resources, glucometers, hemoglobins. Those are really not found in other clinics that are similar to Chifundo.
So basic OB care in Zambia. So urine pregnancy test to confirm, syphilis testing if it's available. They still do HIV testing, and then they do their every 4-week checks up until 32 weeks, and then it goes down to 28 weeks, I guess, and down to 2 weeks, and then down to 1 week after 36 weeks. And then a lot of times once they're at that like 36, 38 week time, they have a mother's waiting house where the pregnant patients can come and stay until they deliver so that they don't have to walk when they're in labor. They, like I talked about before, they do a UA at every appointment, and then if it does show signs of infection, they will treat for infection. And then they do deworming and malaria treatment in all of their pregnancies. And then they do a tetanus shot up to 5 shots. And then once you've had 5 shots, they don't do any more in pregnancy. And then an anatomy scan is iffy. Anatomy scans are done at Chongwe, which is about 30 to 45 minutes from where we're at. And it costs them 50 kwacha, which is about $2 American money. But most patients can't afford that. So even if we refer them to get an anatomy scan because we identified them being high risk, or we're not sure what their due dates are and things like that, whether they get it done or not is pretty iffy on whether they can afford it.
So some of the barriers to care include cultural beliefs that we'll go into a little bit more depth here later on. Definitely the walking distance. It's not uncommon for a lot of our patients to be walking miles, and that includes if they're in labor. And so we've had pregnancies deliver on the road and things like that. And so that is a big barrier to care. And then also the rainy season, as patients aren't ambulating to different places as much. Finances, the average income of most Zambian people is about 300 American dollars a year. And so finances are tight. And then resources in general for the clinic, we don't have the normal supplies that we often just have available here in the United States.
So we'll talk about the cultural and health beliefs of pregnant women in Zambia regarding pregnancy and childbirth. I actually found an article that they had published about these beliefs specifically. So the objective of the article was to explore the health beliefs regarding pregnancy and childbirth of women attending an antenatal clinic at Chiwama Health Center, and this was in Lusaka, so a little bit more of an urban area. The method was they did a descriptive cross-sectional survey of women attending antenatal care who were selected by systemic sampling. So they usually saw about 60 patients a day. So every fourth patient that was at their clinic, they would give this survey to fill out. And a total of 294 women participated in the survey. So some of the things that they had on the survey, oh shoot, it cut off, I'm sorry, that they had looked at was eating a balanced diet in pregnancy. Most patients agreed with that. Eating eggs can cause a baby to be born with no hair. Quite a few actually agreed with that. So they're going to avoid eggs. Eating okra, which is a type of fish, can cause drool. Isn't it fish?
No, it's vegetable.
See, I can't eat tons of vegetable. There is a fish though that they also believe this for because it's on my next, like on one of my other slides. But anyways, they also agree with that. So as you can see, just like eating in general, I've had okra before, which is really sad. Like in general, just some of their nutrition beliefs are going to cause them to not, be eating the right things. And so that can have poor outcomes, smaller birth weights, potentially things like that. The main diet in Zambia as a whole is like a porridge that they make, and then they eat a lot of shima, which is essentially like a rice corn-based
Carb.
yeah, carbohydrate. It's not bad, but that's like what they eat. They don't get a ton of protein. And so that's kind of gonna lead to smaller birth weights. These were also some of the other just like cultural beliefs, not so much on the eating aspect of it. But this one was the antenatal care should be started as soon as a woman knows she's pregnant. So a lot of them in Lusaka agreed with that, 266 women, but then 18 disagreed. And Lusaka is going to be, like I said, is a little bit more modernized. So they aren't quite as affected by the cultural beliefs as to like where we were out in the Rufunza district. There was quite a few more women that believed that you should wait till at least 14 weeks, if not further along in your pregnancy before you said that you were pregnant. So that was one of the biggest, reasons why patients didn't come in right away. And then these are just some of the other ones, that they have that I thought were kind of interesting. Bad rituals can be performed on the soil where a pregnant woman has previously stepped. Unfaithfulness, they have a lot of beliefs against unfaithfulness in pregnancy outcomes, like whether it's the husband or the wife, which can lead to some different things. So I think just in general, their cultural beliefs do change how they do their prenatal care. This was the cultural beliefs from one of the clinic RNs that we specifically saw. So again, they did have the no eggs. When they're in labor, they can't stand on a doorway or the cervix won't dilate. A woman should not be sad because then the baby is born sad. This is what I was thinking of. The bubble fish, so like the okra, can cause a child to be salivating or drooling. Again, pregnant women should not have sex with another man that's not married to because the cervix won't dilate during labor. And then a pregnant woman should not see her blood during delivery until she is clean because if the husband had sex with another woman, she can die during labor. So those are just some of the cultural beliefs that they had came up with for us.
So some of the things that we did to try and support improving prenatal care and intrapartum care in our clinic specifically included teaching the ALSO course, which is the obstetrical advanced course. We also taught NRP, BLS, and ACLS to the providers in our clinic specifically. For the ALSO course, we did have some midwives from the local clinics that did come additional day to learn a little bit about the ALSO course teachings. We did hand out laminated guides on the topics covered in the ALSO course. We taught about fetal Dopplers, continuous monitoring, and NSD evaluation as well. A lot of the clinics outside of Chifundo still use a fetoscope for their main way to see how pregnancy is going. So that is a huge cultural barrier that we found even when we were doing some prenatal care in Chifundo.
So if you don't know what a fetoscope is, this part goes on the abdomen and then this goes on your ear, and you're trying to listen for baby's heart tones through this. It's very difficult. So for the also of course it's very similar to like the one that we do with in residency here. So it just talks about like safety in maternity care, postpartum hemorrhage, late pregnancy bleeding. We talked about shoulder dystocias, maternal sepsis, postpartum complications, third and fourth degree lacerations, cesarean deliveries, breech deliveries. What do you do in malpresentations? Things like that. So just anything that you can think of like in labor that would happen potentially, and to identify some of those risk factors. This was, I think, some of my favorite days. I think it was just fun to just have these discussions with the ladies, and I feel like we taught them quite a bit, which was really awesome.
The clinic also has a sim Noel, and so we were able to do some hands-on learning with deliveries, like delivering sort of shoulder dystocias, breech extractions, which I think is pretty advanced for these clinics.
And we like talked about like what resources that they had there, because like obviously they have different medications than what we have available to us. So that was also really good, just like identifying what you guys have at your clinic specifically, like where is that located? If this were to happen, do you guys all know where your medications are located to grab those things? So I felt like it was helpful overall. And we really enjoyed that.
Part of the other part of our quality improvement project was we taught 2 medical providers, an RN and a clinical medical officer, which is very similar to an APP, how to do first trimester dating ultrasounds. And you can kind of see the picture here. This is myself and one of their clinical medical officers doing first trimester dating ultrasounds to help confirm, pregnancy expectation or dating, which is a huge thing that isn't really done. And having that available in the clinic really brought in a whole lot of more patients and just helps with care in pregnancy. We also introduced them to our CFM residency app on risk stratification, mostly looking at preeclampsia risk specifically.
So the OB app, it's like like Dr. Selvey said, it's a risk assessment tool. It screens for perinatal risk factors. So the ones that we have on there is like preeclampsia, thyroid disease, gestational diabetes, preterm labor. But like she said, we were specifically focusing on preeclampsia for them, mainly because right now Zambia, as a country, is doing a study to see about using aspirin with preeclampsia. It's not approved for preeclampsia use in Zambia right now, so you can't widely use it across the board. But if that were to be passed, then we are already like one step ahead with the risk assessment tool. So they've already like implemented this. So then once they identify it, they'd be able to give their patients aspirin. This was created by Dr. Ball and Dr. Huntington at CFM. And then this is just what it looks like. So you just go through and it, does risk factors, age, ethnicity, low socioeconomic status, nulliparity, multi-gestation. So a lot of our patients just based on this are going to be high risk for a lot of different, preeclampsia and preterm labor. And then it just goes through like stillbirths, pregnancy loss or infertility, microsomia, greater than 10-year pregnancy intervals. And then based on what you click yes or no to, it tells you like, should you do aspirin for preeclampsia, thyroid screening, should you get an early A1C, things like that. But again, we were kind of wanting them to focus on that for now, and then we can implement other things later.
Yeah, and so really what they're doing is they're putting each patient that they're seeing into this risk identifier and then just saying, are they at risk for preeclampsia? And so really it's just that early stages of, can you identify a patient that is at risk? So part of the evaluation of our quality improvement process looked at our monthly totals for first antenatal visits that were performed prior to 14 weeks. We also looked at number of dating ultrasounds performed, number of pregnancy tests performed, and then number of individuals that were actually identified as high risk for preeclampsia through the utilization of that OB app.
The results. So we started training the medical providers in July and August when we were there in 2021. And then the data was collected between July and December of 2021. And that's what we'll kind of show here.
And so this first graph just looks at our data for just urine pregnancies performed alone. So This is when we came into Zambia. And so you can see the number of pregnancy tests performed have been quite high, which has been good. That's part of our initial screening for just identifying pregnancy. So you can see that it's actually being done.
In December, the reason it probably started to slope down a little bit is you're starting to get into like that rainier season. So we do expect there to be a dip in the number performed through the rainy season.
And then this just goes month by month for number or percentage of visits that were done prior to 14 weeks. And so in July, we kind of started around 39%. That was after some teaching. We were there maybe like 2 weeks before the end of July. So that's a little bit of the data that we were kind of encouraging them to see newly diagnosed pregnant patients on that day. And you can see it's generally increased from the 28% that was previously described as visits that occurred prior to 14 weeks. And Dr. Hyra was just telling us that in February, we actually reached our goal of above 60%, and it was 75% for the month of February. And this is just identifying that patients at risk for preeclampsia. And you can see, really no patients, very few were being identified prior to us coming into the clinic. And then shortly after the utilization of the OB app, we started identifying quite a few patients that are at risk. And this has probably trended off a little bit because of the rainy season as well.
Some of the limitations to the study in general. So the patients that we are seeing are obviously from one clinic in Zambia. So it's a very small sample, or like generalization is going to be tough across the board. It's a small sample size because again, it's just whoever is coming to that clinic specifically to be seen. The data is self-reported, so we're relying on their clinical medical officers to give us all of our data. They do report this to the Ministry of Health, but it is all self-reported data, so there could be some of that's off. And then there is a time limit to this study. So originally it was only going to be for 2021. We did get that approved to expand through 2022. So we'll have a full another year of data to kind of go on. Like we talked about, the rainy season does affect numbers just based on how many patients are going to come to the clinic in general. And then resources, again, financial, distance, and culture, they just potentially won't come to the clinic for those reasons too.
So some of our conclusions. So through the implementation of universal pregnancy screening, we were able to increase the percentage of antenatal care visits that were actually performed prior to 14 weeks from 28% to an average of 44, which is probably even greater now since our data continues to increase. We have additionally been able to identify people who are at high risk for preeclampsia and done that early education for the medical providers at that clinic so that if and when the aspirin is approved for using in pregnancy, that will be an easy transition, hopefully, for them. And now we're able to offer first trimester dating ultrasounds and have been consistently, which I think is just another thing that, no longer, at least we're having an initial ultrasound. A lot of people are still not going to get an anatomy scan, but we have one more thing that we can offer them. We didn't reach our goal initially of the 60% of first antenatal visits before 14 weeks, but now we have into February, which I think has been a pretty huge success for our quality improvement project, and just overall trying to improve access of care to these individuals. If they can get it at our Chifundo clinic, that's a lot easier than having to refer them to Changwe or Lusaka for their other care. And then I think, just educating our Chifundo providers on risk stratification has been a huge thing too.
So what's next? Dr. Hyra, in one of our current second years, who will be a third year when she goes, will return to Zambia in July of 2022. They'll continue to work on kind of our project, and then they're actually going to start another QI project there too. And then our QI project data will continue to be collected through 2022. So we'll just have more data to extract over the next year.
And I think the big thing that will, determine how successful this has been is pregnancy outcomes. So, time will only tell if we've really made a difference by increasing, those antenatal visits.
These are some of the resources that we used Here's some acknowledgements and thanks for people that we talked about. So first off, the Rafunza District Ministry of Health team. Without their approval, we wouldn't have been able to do the QI project or really go to Zambia in general. So their approval was huge for us. Dr. Heyer, who took us to Zambia, we wouldn't have been able to do that without her. Center for Family Medicine, Chifundo Clinic, and their health workers. Dr. Matt was a doctor that we met down there, and he kind of helped teach, and then he showed us some of the Lusaka hospitals, and then just some of our sponsors as well. So while we were in Zambia, we were able to have a little bit of fun. There was a refuge or sanctuary that had cheetahs that you could pet. So you can see there's Dr. Heyer, Paige, and myself petting the cheetahs. And their names are Chimanuka and Cheepo. There you go. I don't know which is which, but that's their names. And then this was us on outreach. So those days that we took the van and we did outreach, which we did education at outreach. And it was kind of like a well child check where they would get their immunizations, the kiddos would. And then there is usually birth control and then some education topic that we did that day. But here you can see Paige and I maybe took a little break and we're playing with the kiddos. And then, yeah, we were telling stories here. And then he was our translator. So it was a lot of fun. Any questions?
High risk for preeclampsia. What happened next?
So usually they could be referred to Chongwei to deliver into a higher level of care. Whether or not they would go would be the question.
They did have medications. They had Meg.
Yeah, so we did if they were diagnosed with preeclampsia.
Not everybody has.
Right.
Yeah. We had magnesium, and we also had blood pressure medications.
Yep,
too.
Procardia and some of those medications. So I mean, if they were identified with high risk, then they could have the option of referral to Chongwei. If they were diagnosed with preeclampsia during pregnancy, they have MAG available at Chifundo. But it would be a referral to another center.
So if you do identify a high risk pregnancy or in labor, a patient that's high risk that needs to be referred, there is an ambulance that comes from Chongwei to the Chifundo clinic. However, it's hard to know how long it's going to take for the ambulance to get there. First, if they would come directly, it's at least a half an hour. But what you do is you call the Ministry of Health physician and you talk to him and you say, hey, I need a referral for this reason. And then he either approves it or denies it. And then if he approves it, then they call the ambulance to come. But if the ambulance is out, there's one. So if the ambulance is out doing something else, it could be a while before they got to you. So how long it takes to get is kind of a little bit rough.
You should tell your experience about the midwife.
It was interesting.
So what Dr. Heyer is talking about is one of our patients did go into labor while we were in Zambia. And in Zambia, if there's meconium in the amniotic fluid, it's almost a for sure C-section. And that's just because of their beliefs, I think, regarding aspiration of that. And so we had to make a call for a transfer. And the cultural beliefs in Zambia are so strong in some areas that they refused to listen to us with our Doppler saying that the baby was doing pretty well. We were getting fetal heart tones of about 130s. But the midwife that came was using a fetoscope. And I believe she was picking up maternal, but she
60s heart rate
was saying that the heart rate was 60s, but even that, the urgency for transfer is really not there. And so there's just a lot of areas that continue to be able to be improved. But outside of Chifundo will be the next step, I think.
The baby was born healthy and fine. We did hear that the next day.
We have a question in the chat.
Yeah.
Says, I might have missed it in the beginning due to my sound issues, but what program is this opportunity involved with, or is it independent?
So Dr. Heyer actually had went to Zambia and was staying there for 8 years prior to moving back to the United States. So she was the one that was involved with the clinic, and she was the one that kind of shaped the clinic. So we went through like Dr. Heyer and the Ministry of Health to go.
If someone wanted to go, they should apply through CFM.
Yeah, so reach out to Dr. Heyer at CFM if someone's interested in going. When we were going, actually, originally, we were supposed to have a lot of other teams going with us. So there was supposed to be like an ophthalmologist going with us. I was gonna do like eye surgery, and then we had a couple other teams that were gonna go and actually do the teaching. But then due to COVID and things like that, they weren't able to go. So there's definitely a lot of opportunity in the clinic that we have is set up pretty well for outreach there.
Any other questions? All right, thank you.
I visited the health system in Cuba, Ripple the People program.